Good afternoon, all the aspirants present here. We'll be starting with the day three of our crash course, which will be taken by Dr. Arun sir. Sir, you may share the PPT and start.
Good afternoon there in India. Good afternoon, everyone. So, welcome to the day three of EDIC Part 1 crash course. Hope you are enjoying the course so far. So, myself, uh, I am working as intensive care physician in London currently at Guy's and St. Thomas Hospital. So, last year I took a course with Farz Academy and cleared my EDIC exam. So, since then I have joined as a faculty in the Farz Academy and has been teaching. So, So welcome to day three again. If you're a follower of cricket, you know how incredible the story with the recent test match in Lords. Uh, yeah, there was no hope for India on the last day of the test, but this man Siraj had belief in himself, kept bowling. The day started with a four, so I thought we lost the match. I switched off the TV, but later on found India won just because of Mohammad Siraj. So don't stop believing in yourself. Keep believing till the last moment, even if you're not doing well, even in the exams, if you're like not sure of the answer, most of the answers, keep believing in yourself till the last MCQ. You never know. It may be a tough exam, so don't stop believing in yourself. And few rules for today. Let's try and keep it as much interactive as possible. Uh, it's I've set the session like few MCQs. We will work it together and have a discussion on it rather than just keeping it like one-way discussion, like a lecture. I wanted to make it more interactive. So make use of it, treat it like a mock exam, and if possible, keep your videos on and keep your Zoom ID as your name so that I can address you by name. And yeah, we will go through the MCQs and go through some concepts behind those MCQ as well. And at any point of time, feel free to interrupt and clear your doubts. Okay, ready? So I need you guys to answer this. Then I will come up with my answer and we will discuss through as we go through like every MCQ. So the first topic is going to be trauma and then traumatic brain injury. And the next session will be burns and obstetric hemorrhage. First question, 35-year-old male following a high-speed motor vehicle collision is transferred to the trauma center. He is intubated and has a stable pelvic binder in place. Blood pressure is low, heart rate is high, he is cold, clammy. After 2 liters of crystalloid, there is no improvement. So, what is the most appropriate next step in the management? Please unmute yourself and come up with an answer. Those who are online or put in the chat box, I can pick it up. Then we can go through. So someone is saying C. Yeah. Any other answers? There are quite a few participants. Yes. Okay. A couple of them answered C. One says A. So let's see the answer. Yeah, I agree with the people who said C. Uh, yes, this patient is hypotensive despite giving fluids. So with regards to answer for A, that will be my second option. I mean, in terms of fluid resuscitation, we won't go continue with the crystalloid resuscitation. We will prefer to have a blood products and uh, colloid resuscitation as a second line. But more important thing in this patient, especially with the stable pelvic binder, so there is a strong suspicion of a pelvic injury. And this patient is not so stable to have a CT scan of his chest, abdomen, pelvis done in urgent basis. But what we can do in an emergency situation is do a fast scan, and if it's positive, request the interventional radiology to be on standby. So as we resuscitate, we can do the scan in the interventional radiology suite and embolize the bleeding vessel as we go. And with regard to the other answers, Yeah, NORAD is not the first. Somebody has asked in the chat, like, should it be the most it is one of the options, but is it the most appropriate one? I'm not sure. So if there was a option like give blood products first, I would have been confused myself whether to go for the blood first or do a fast and aim for interventional radiology. So that would have really confused you, but it's very clear here. So if you want to resuscitate the patient as we go along, yes, blood products is the next line. If it's not responding to the blood products and you have a suspicion of a spinal shock where the heart rate is low, the blood pressure is low as well, then yeah, noradrenaline take a preference over the blood products. But in this case, I think C is the most appropriate next step in this management of this patient. Yeah, if blood products was there, I would have gone for that first, but I wouldn't have gone for noradrenaline as my first choice. So I would still go for C. And diagnostic peritoneal lavage, it was used previously, but it's going out of favor with like ultrasound scans coming up, and more people are getting trained in doing a fast scan in the emergency, so that's easily available. So diagnostic peritoneal lavage is out of favor nowadays. So I agree with this answer of C. Let's move on. If you have any doubts, want to discuss, please unmute yourself and ask the doubt so that we can have a discussion. Right. Second question. Which trauma scoring system does not require knowledge of anatomical injury and predicts mortality accurately? This is more kind of a NEET-like exam rather than EDIC Part 1. EDIC exam is more like a clinical-based exam, so it doesn't test your memory much, but it does test your understanding of your concepts and clinical application. So this question I included just to emphasize on the fact that uh, if you have been exposed to the EDIC modules like the study materials available given by the ESICM, the ACE module, those are really good. I strongly advise you to go through some of the topics, important topics at least, uh, before like going through the other MCQ books or anything, because some of the questions directly come from those materials. So I strongly advise. So this question I have taken it from that module of trauma module of ESICM. So yeah, go for it. What do you think is the right answer? There is no negative marking in the exam or not for this discussion. So go for it. Come up with an answer. What's your best guess? E, D more than C. I agree with D. I agree with D. Yeah. So the correct answer is D. It's emergency trauma score. So let me go through the other scores in case you're not aware. So abbreviated injury score is basically to assess the severity of injury of one particular organ or a system. So we allocate like 0 to 6, 0 being the least severe, and 6 is like fatal injury. So it just to, there is a elaborate guide on how to assess the severity of each organs if you go through the score in detail. So, but so this is just to say like this liver as a grade 3 laceration, so that will come somewhere around 4 for the AIS score. So the injury severity scale uses the abbreviated injury score of each particular system. So there are like 6 systems: face, head and neck, chest, abdomen, extremities, and external. So these 6 are the components of ISS, and whichever scores the top 3 in terms of AAS, it is squared and it is added to give us a value. So in any case, if the AAS is like 6, that means it's a fatal injury. Automatically, the injury severity scale will be like 75. If not, like for facial injury, the severity scale is 2, or chest injury, the severity scale is 3. So we square each individual, the top 3 AAS scores, and it is added. It does give a good assessment of the injury in a patient, but it's not a good predictor of mortality, or it does require an in-depth knowledge of anatomy. So both A and B are out of the options. So the revised trauma score is more like a SOFA score, like GCS, respiratory rate, and systolic pressure. Each is rated like 0 to 4, and good for triaging because it's based only on clinical assessment and the quick observations of vitals. So it's easy to triage, but it again doesn't predict mortality that well. And emergency trauma score, this is a good score because it's very objective. It's based on age, GCS, and a gas and a clotting, base excess, and prothrombin time. And it has shown to predict mortality accurately, although it's not widely used everywhere, but for MCQ purpose, this is the answer. And TRIS model, so it's a mathematical model which combines trauma score and ISS and comes up with a prediction of mortality. It's quite accurate, but it's again requires complete investigations like CT scan done before we get a value for this, and it's more useful for a research purpose rather than clinical application. So there we go. Any doubts with this? Otherwise, I will move on to the next question. Right. A ventilated trauma patient after intubation develops a sudden rise in peak airway pressures, hypotension, tachycardia, and decreased breath sounds on the right side. Trachea is deviated to the left. What's the best immediate action? We've almost given you the diagnosis, so what will we do next? Okay, a couple of you answered B, one of you answered B. So I added a E just to make it more interesting. Yeah. So this is obviously tension pneumothorax. Everybody can come to that conclusion. So when it comes to tension pneumothorax, first thing to do is needle decompression. Even as you are preparing for chest drain insertion, needle decompression always the first to answer in any exam or even clinically, first thing to do. We don't wait for a chest x-ray. We don't try with fiddling with a ventilator, or just get a needle and decompress. If anyone can unmute and answer, how do you perform the needle decompression? It would be helpful. Come on, guys. How do you do a needle decompression?
Using a 14 or 16 gauge wide bore needle in the second intercostal space mid clavicular line. But before inserting the needle, we have to make a water seal so that outside air doesn't go in during inspiration, negative pressure generation. So we have to create a water seal by the time, and we have to decompress and connect it to the water seal down. So we can cut a NS bottle halfway filled, and the end of the IV drip set we can dip inside the half filled NS bottle and connect the end towards the needle.
Interesting. You are absolutely correct in going for the needle decompression in the second space. The second part of your answer is not given in any guidelines or anything. Maybe some individual practice or somebody's advised you like that, but it's not advisable. You just put in a needle and decompress. That's it. Nothing else to do. You can take out the needle and go for a chest drain. You don't need a water seal just for needle decompression. And one more thing to add to your answer is, yes, anterior mid clavicular line is advised, But the most recent guidelines, even from the ATLS, suggest to go for an anterior axillary line where you usually go for chest drain. So as you prepare for the chest drain, you can just needle decompress as first step, and then you can put in the Seldinger technique or open chest drain. And whiteboard chest drain is advisable over a Seldinger technique. I don't know how many of you have used the Seldinger technique. It's just like inserting a central line. Basically, you put in a guide wire and use a small board chest drain, but open like whiteboard chest drain with the conventional approach is preferable. And I agree there with you with the under seal. We do need an under seal, water under seal for the chest drain, but not so for the needle decompression. Is that okay?
Yes, sir.
Cool. I mean, fairly simple question, but you get a lot of simple questions in the EDIC. And it's important you don't get these things wrong because EDIC exam doesn't score you like our Indian exams like NEET. It scores it assesses your performance in relation to the other candidates and the exam, the toughness of the exam, of the questions. So if you miss out on easy questions, then that definitely drops your marks rather than getting a tough question correct, if you understand what I mean. Yeah. Uh, so, yeah, C, straightforward, isn't it? Uh, so the trauma guideline says the trigger should be less than 7, and we aim for 7 to 9. So unless even in actively bleeding patients, so this is what the evidence says based on RIC trial, which compared like lower transfusion trigger and higher transfusion trigger, like up to 10. And yeah, there was no clinical difference, and there was some evidence for harm when we have a higher transfusion target. So even in actively bleeding patient, our trigger should be like 7. But in the clinical sense, if the patient is unstable, you don't look at the targets. This is more kind of, as the question says, recovering from the active resuscitation phase. That's when you actively measure the hemoglobin level and aim for it. If the patient is unstable, you will try to resuscitate and give blood products without actually looking at the numbers. That doesn't make sense in a like deteriorating rapidly hypotensive patient, but it does make sense when the patient is like borderline hypotensive, it's stable, and you can have a look at the numbers and treat the patient. Right. So there are some terminologies like this: damage control surgery, hypotensive, permissive hypotension, hemostatic resuscitation. So we need to be clear about the concepts of what these terminologies mean. It's explained nicely in the ESICM trauma module, but we haven't please go through it. What do you think is the answer here? Yeah, I agree with you all. It's straightforward, isn't it? So it's part of the damage control resuscitation we do. So we allow for a lower blood pressure target if the patient doesn't have a traumatic brain injury. Yeah, I thought somebody was about to ask a question now. Yeah, so damage control surgery aims for this control hemorrhage, limit contamination. So once the patient is stabilized, then we kind of go for definitive management. So other options are not correct. Cool. So nasogastric tube insertion is avoided in patients with the following signs, except PG, is that Pankaj? I'll call you PG then.
Premanshu.
Sorry?
Premanshu Ghoshal, sir. PG.
Okay. I'll call you PG. I like PG. If that's okay. Yeah, I agree with your answer. Anyone else? Do you think otherwise? So why do you think E is the correct answer?
So all the others signify base of skull fracture, sir. Periorbital ecchymosis recognize that is the blackening of orbits bilaterally, or masculine ecchymosis that is battle sign, or CSF rhinorrhea that signifies cribriform plate fracture, or the hemotympana. But subcutaneous emphysema is may not be related to base of skull fracture. It is mostly related to pneumothorax. So it's not contraindicated to put a nasogastric tube in subcutaneous emphysema. So we can put that actually.
Yeah. So even for the other base of skull fracture, it's not an absolute contraindication. If we have like undervision, if we are doing it, it can be done, but advisable is a orogastric tube in the suspected base of skull fracture.
Otherwise, you can put endoscopy guided RT in such
Yeah,
cases.
yeah. So it's not an absolute contraindication, but if you're doing it blindly, oral gastric tube is preferred. Yes, I agree with you. Subcutaneous emphysema is the odd one out here, so that's the answer. All right. Which of the following is the most sensitive early indicator of adequate resuscitation in a hemodynamically unstable trauma patient? Normalization of heart rate, normalization of blood pressure, increased urine output, resolution of lactic acidosis, or normalization of base deficit. So Shrikant says A. Do the others agree with Shrikant? B says B. Okay, so our right says C. Interesting, we have a mixture of questions, a mixture of answers. But my best answer is resolution of lactic acidosis. So I will explain as best as I can. So the heart rate, blood pressure, I agree, it can normalize, and the urine output as well. I mean, all five can happen, but what is the most indicator? If you look at all the options, there are confounding factors for each one, right? Despite adequately resuscitating the patient can still have tachycardia due to other reasons like pain. And again, that goes with the blood pressure. Blood pressure can be high as well, but can be low because of other reasons like spinal shock. Urine output, again, how much we are monitoring it in the acute situation, and with pain and AKI, renal injury, it can affect the urine output. So it may not be the best indicator. Lactic acidosis, it's one lactic acidosis and base deficit are objective markers. And if you just closely look at the options, says like resolution of lactic acidosis and normalization of base deficit. Normalization of base deficit can be a bit delayed compared to resolution of lactic acidosis. So I'm intended to go with more of resolution of lactic acidosis rather than base deficit. Both of them are like close to each other in terms of being the most sensitive indicator, but I would rather go with lactic acidosis, which I think is the most appropriate answer. Yeah. Moving on, a trauma patient with multiple risk fracture, sauna pressure control ventilation mode, saturation is 88 on a FiO2 of 80% oxygen, PEEP of 12, So what is the next best step to improve oxygenation? Increase the FiO2 to 1, switch to a volume control mode, increase the respiratory rate, initiate a recruitment maneuver, insert a chest tube prophylactically. Speak on phase D. What about others? Yeah, so I got a couple of D's. I agree with them. Initiate a recruitment maneuver. So this question is interesting. The options, if there were like options for proning or ECMO, it would have been more interesting, I felt. So here the answer is recruitment maneuver, which is what we do clinically. We do a suction, we bag them, or we do recruitment in some way or other. We as the chest we used to see them, isn't it? But if it's refractory to, yeah. So that's a good question. That's what I wanted to ask you guys. Is it a contraindication with rib fractures per se? We don't know if it's plain chest or not. With multiple rib fracture, is it a contraindication for proning? Yes. It's not absolute contraindication, but it should be seriously taken into consideration. We should make sure that we are not causing more harm. We should be more careful in doing the pruning, but it's not absolute contraindication. And yeah, if pruning doesn't work either, we should think of ECMO as well in this patient. So these are good candidates for ECMO. Usually they are young, robust, without multi-organ failure, so they do recover quickly. And another point to note here is with multiple rib fracture, if the patient is requiring a lot of oxygen despite being ventilated or despite adequate analgesia. So these are the, there is evidence coming up like uh, in multiple rib fractures, surgery is not the first thing to think about, right? Even the surgeons say it's conservatively managed most of the time. But recent evidence coming up like closed reduction, like open reduction and internal fixation of the rib fractures do help in such a small like subgroup of patients with multiple rib fractures are not doing well on ventilator. They do have better outcomes with yearly surgical management. So if that comes up an option, that is something to be considered as well. So there is evidence coming up. It's not robust, but there is good, great evidence for yearly surgical management, which was recently discussed in a conference I went to. So that might come up in the MCQ. So keep a watch out for that. Which transfusion strategy reduces mortality in massive transfusion for trauma? This to 1:1, 1:1:1. Restrict platelets less than 50, FFP. So this is an easy one, right? So you guys got it right. So this is based out of the proper trial, PROPRR software. So which basically said 1:1:1 is good for mortality. There is no, I mean, it's overall good for the patient, and there is no difference compared to other ones, but theoretically it has a good sound basis for why we do this, and outcomes as well are good with this ratio. So bit of a straightforward one. And do you know if there is a platelet target? What do you think is the appropriate platelet target in a bleeding patient? You think it's 50 or aim for 100 or somewhere between 50 to 100 or 20,000. That's interesting. With respect to platelets, the guidelines do very badly. They don't give a clear cutoff, and different guidelines give different cutoffs. So we actually don't know. We don't know is the right answer. But clinically, what we try and aim for in actively bleeding patient is aim for more than 50 to 100. And that depends based on an individualized patient ratio. Currently, there is a trial going on in UK. It's called Threshold for Platelets. It's basically for like low risk bleeding procedures, and they are trying to find a cutoff from 5, like 10,000, 20,000, 30,000, 40,000, or 50,000. So they have like 5 arms in the study, and they are randomizing and seeing which is the best platelet threshold. So in few years' time, we might know the answer. I'm one of the co-investigators doing a small role in the study. So let's see what the study shows up in the future. So for this question, this that's it. So which agent improves survival in traumatic hemorrhage if given within 3 hours of injury? Yeah. And which study is related to which study suggested like good mortality outcomes, clinical benefit if we have given within 3 hours? Yeah, crash 2 to be precise. It's correct. And crash 3 came up with some suggestion like even in traumatic brain injury, if given within like 3 hours, it has some benefit. Exactly. So, hang on. 45-year-old male was admitted to the ICU following a severe traumatic brain injury, the low GCS. ICP monitor is used. And so what is the primary goal for managing a CPP? So what is our target? More than 50, 60 to 70, more than 90, 50 to 60, less than 110. Yes, you're all correct. So we aim for a 60 to 70. So basically, cerebral perfusion pressure is the difference of your mean arterial pressure and intracranial pressure. If the ICP is increased, we try to counteract with increasing the mean arterial pressure or simultaneously decreasing the intracranial pressure and maintain the cerebral perfusion pressure, which is our target. And Brain Trauma Foundation gives us this target of 60 to 70. And there are other guidelines which, if we, not everyone like monitors intracranial pressure, right? So indirectly, we try to maintain the mean arterial pressure of more than 80 at least. But interestingly, Association of Anesthetists give a higher target of a map of more than 90, and Brain Trauma Foundation gives a systolic blood pressure target of more than 100 or more than 110 based on the age group. Quite specific targets. Yeah, so that's where we are. And whether actually mean arterial pressure manages to increase the cerebral perfusion pressure, we don't know if it happens in all the patients unless we do intracranial pressure monitoring. We will look into that in more detail with another question. But any questions here? In the management of a patient with severe traumatic brain injury, which of the following is a level 1 recommendation from Brain Trauma Foundation guidelines? Prophylactic use of hyperventilation, administration of high-dose barbiturates, avoiding the use of corticosteroids, routine use of hypothermia, maintaining a serum sodium level of more than 160. Yeah, a couple of you have said C. Yeah, I agree with you. It's easy to exclude the other options actually, rather than even if you don't know like if C is the right option or not, you can just exclude the other options easily here. Yeah. So that is the only level 1 recommendation given by Brain Trauma Foundation. Avoid use of steroids in brain trauma for just for the sake of reducing ICP. The rest of them are like at best 2A, but this is the only level 1 evidence given by brain trauma. One patient with a severe traumatic brain injury is being ventilated. The ICU resident suggests increasing the respiratory rate to lower the PaCO2 to 30 millimeters of mercury in an attempt to reduce intracranial pressure to 22 millimeters of mercury. What is the major risk of this strategy? So what are we worried about lowering PaCO2 too much? Yes, you are all correct. See, and I like this graph very much. I got this from Miller's textbook of anesthesia. So it explains the physiology and relation of cerebral blood flow with mean arterial pressure, PaCO2, and PaO2. So if you look at PaCO2, so it's a steep curve. So the more you lower the PaCO2, more the cerebral blood flow comes down. So you don't want to lower it too much to cause poor cerebral perfusion. So we need to maintain a mean arterial pressure. Despite maintaining a mean arterial pressure, your cerebral blood flow can come down. So you don't want that happening. So that's why we use PaCO2 like hyperventilation only as a temporary measure before you can get the other agents to start working. Maximum of 30 minutes, I would say, not more than that. So if you continue to hyperventilate the patient, there is severe risk of cerebral hypoperfusion and increased cerebral damage. So don't do that. And so with respect to the mean arterial pressure maintaining like more than 80, does it work in all the patients? No, it works only in certain patients where the blood-brain barrier is breached. So if the patient's blood-brain barrier is intact and the cerebral vascular reactivity is intact, even if you maintain a higher MAP, it's not going to affect your cerebral blood flow. So in normal patient, it's not going to make any difference at all. So that's why some of the guidelines suggest give a MAP challenge, like give a vasopressor, see the increase in MAP. If you are measuring intracranial pressure, measure the intracranial pressure if it's coming down or the cerebral perfusion pressure if it's going up. Then it suggests the technique works, like aiming for higher MAP. Otherwise, it doesn't matter, however, like whatever MAP you maintain. So this is what I was trying to explain with aiming for a higher mean arterial pressure. It's kind of a blind guideline. And often we had to use some noradrenaline or any other vasopressors to achieve the target, which complicates the central situation. And if you look at the oxygen and the response to cerebral blood flow, lower the PaO2, after a stage plateaus. So adjusting the PaO2 is not going to alter the cerebral blood flow much. So you just aim for a normoxia rather than hyperoxia or hypoxia. Rather, you would avoid hypoxia. Cool. If you have any questions, do ask in the chat or unmute yourself. I'll keep going with the next question. So a patient with traumatic brain injury develops polyuria. Yeah, so you already come up with the answer. Yes, I agree with you. There is no doubt this is diabetes insipidus. If the question had hyponatremia, what would have been your answer? So Dr. Jacqueline, if I'm calling you correctly, says B. Yeah, I agree with you. Can you explain why you said B?
Hi, afternoon. So in a traumatic brain patient who then becomes hypovolemic with a low sodium, that patient would then actually have cerebral salt wasting, because they'll be losing the sodium.
Yeah, you're absolutely correct. So, if hyponatremia, so the main differential, and we need to differentiate the SADH and the cerebral salt wasting. It's just a bit tricky to differentiate. So the main pathology, I mean, this pathophysiology behind it is cerebral salt wasting. There is excessive wasting of salt and water. Whereas SADH, you're just losing uh, electrolyte, but not the free water. You're retaining more of free water. So if the patient is euvolemic, it's in favor of SADH. When the patient is hypovolemic, it's more in favor of cerebral salt wasting. You can easily find out who is hypovolemic, but it's difficult to, I mean, just with clinical assessment, say the patient is euvolemic. So it's always a bit tricky. And even the other investigations like urine sodium, it's going to be elevated in both the patients, but it's going to be elevated very high, if like more than 100 or something of urine sodium. It's more in favor of cerebral salt wasting rather than SCADH. But it's important in differentiating these two because the management strategy is different. Uh, SAADH, you need to restrict volume. That is the first line. And for cerebral salt wasting, you need to correct the hypovolemia. So you need to give some fluids. So it does make sense in differentiating these two when they are hyponatremic. Yeah. How do you treat diabetes insipidus? What is the management? That can be asked in the question. Yeah. Desmopressin, yes. And try to control the sodium as well with some dextrose infusions, or even vasopressin is sometimes used if the patient is requiring some noradrenaline. Sometimes we just switch to vasopressin, which has similar kind of action to desmopressin. So even that is an option. Good. Which of the following monitoring modalities provides continuous information on cerebral oxygenation and metabolism at the bedside? Transcranial Doppler, jugular venous oxygen saturation, brain tissue oxygen tension monitoring, EEG, or a CT. Okay, couple of you have answered C, couple of you have answered B. Okay, this is interesting. So let's try and rule out. CT is definitely not the option. EEG is a good bedside monitor, but it doesn't say anything about the cerebral oxygenation. It just indirectly implies if the waveforms are bad, your perfusion is not great. That's not the correct answer. Transcranial Doppler, I really like the transcranial Doppler. It gives a lot of information by the bedside, but it is somewhat limited in telling information about oxygenation and metabolism. It does say about, it suggests if there is vasospasm in case of like subarachnoid hemorrhage, where the pulsatility index is high and the Landau ratio when you compare it to the carotid like velocities. So it can suggest like vasospasm, or if it's absolutely absent, suggest like brain death, patient is approaching brain death. And if the pulsatility index is high, it suggests increased intracranial pressure. So it's more of value when you are like serially following the trend, and it needs like someone who is very good in doing transcranial Dopplers. So that's not the right answer. So between B and C, it's a bit tricky, isn't it? So jugular venous oxygen saturation, what you do is put in a cannula like a central line, which is mostly a single lumen, in the reverse direction towards the jugular bulb from the internal jugular vein and get the saturation. It's like a mixed venous saturation for the whole body, but it gives a value of oxygen extraction throughout the brain. But if you focus on the question, it's more asking for cerebral oxygenation. You're not worried about the entire brain venous extraction. So that's why I would go in favor of brain tissue oxygen tension monitoring, which is basically the nurse. So it gives like cerebral oxygen consumption. That too, we need to monitor like both hemispheres to actually give us any value in clinical interpretation. Just go to delivery. It doesn't say much about metabolism. So for metabolism, I think dialysis catheters and measuring lactate, pyruvate gives more information on metabolism, but just tissue oxygen monitoring just gives the oxygen extraction. Yeah, again, why I think a C is more in favor is because we are aiming for like we are looking at cerebral perfusion rather than entire global perfusion of your brain. So I think that's these two answers are a bit tricky to tease out which one is the better, but I think C is the correct option. Right. Cushing's triad, signs indicative of critically elevated intracranial pressure includes. Yeah, it's a bit straightforward question, to be honest. Nothing big to discuss about this. Yeah, you're all correct. A is the answer. Okay. If patient with confirmed basilar skull fracture should be monitored for which of the following delayed complications except yeah, if you are unsure of the answers, try to rule out the other options so that you can arrive at the answer and take the best guess. A couple of you say D. She can't say C. Right says A. Okay, so this is an interesting question. So even if I didn't know anything about this question, just the word says delayed complication, and extradural hematoma is never a delayed complication, right? So it presents in the acute phase. That's the first thing you look for and treat it. So that is the answer. E is the answer. But let's go through each options. So basilar skull fracture, how the carotid artery injury is a delayed complication. It is again something which presents acutely. It's like obvious, but basilar skull fractures are notorious for delayed carotid complications. Like in the first instance, patients may have a small dissection or a carotid hematoma or a pseudoaneurysm, which doesn't present immediately, but may take even weeks and years sometimes to present with a pseudoaneurysm getting infected or bleeding. One of the things which presents acutely is like dissection or caroticocavernous fistula, but even these complications can occur after a few days. So that's why it's important to monitor for these vascular injuries in basilar skull fracture. So that's why carotid artery injury is not the answer. Meningitis, for patients with CSF leak, they are at risk of delayed cerebral infections, CNS infections. So that's the correct answer. I mean, that's expected delayed complication. And hydrocephalus can occur as a delayed complication because of some obstruction. And cranial nerve 1 palsy, because it's in the base of skull, so does get damaged quite often, but it doesn't get picked up until the patient is awake and able to say it out like, I'm not feeling any, not having any nociception. So we usually detect it in a delayed way. So that's why that's correct as well. So extradural hematoma is the odd one out. So that's the right answer. The recommended target for serum sodium concentration in a traumatic brain injury patient being treated with hypertonic saline for intracranial hypertension is, so what is our target for sodium level? What is it? What is advised in the guidelines? Yeah. So B is a straightforward one. And how do you achieve that? Yeah. That's correct. Hypertonic saline. Yeah. So there are different hypertonic saline combinations available, like from 3% up to 23.4%. We don't know which one is the best, and whether to give is a bolus or an infusion. There is no clear suggestions from the guidelines. So practice varies from center to center. In our center, we just give bolus. We don't give infusion, 3% saline. Okay, we are nearing the end of the first session. A patient with traumatic brain injury and external ventricular pain in a place for ICP monitoring and drainage developed sudden headache and decrease in level of consciousness. ICP reading is 5. The most likely explanation is monitor is malfunctioning, patient has improved and traumatic brain injury is resolving, EVD may be blocked or kinked, patient has developed diabetes insipidus, patient is experiencing severe vasospasm. Yeah, so a couple of you think C is the option. I agree with you. Yeah, we need to basically call the neurosurgeon to come and have a look at the EDD. I'm not going to fiddle with it myself, but I will call for it. I'm suspecting it's blocked or giving under reading. That's why the ICP is low, but clinically the patient is looking like the ICP is high. So I will troubleshoot the EVD before the thing. That's correct. And these are some waveforms which you might be asked in EDIC part 1 or part 2. So the first graph, so this is the normal looking ICP waveform. This is just like an arterial waveform, CVP waveform, but the scale is very low. So it has 3 waveforms, so P1, P2, and P3. P1 is the systolic arterial waveform basically, and P2 varies, depends on the compliance of the brain. And P3 is like a dicrotic notch when the aortic valve closes. So that's a reflection of that. So the P here it shows blunted P1, slightly increased P2 compared to P1, and the normal P3. So this waveform is suggestive of a increased intracranial pressure or poor brain compliance. So that's why the P1 is low compared to P2. So this suggestive of this is not normal, this is abnormal and suggestive of poor cerebral compliance. And if you trend the ICP values over a period of time, so the C waves, these are called the Lundberg waves. So C wave is a normal variation from like 15 to 20 of ICP over a period of time like 10-15 minutes. Minimal variations are acceptable. But while you look at B wave, so we are getting sudden spikes for like increased ICP up to like 35, 40, and it comes down on its own. And it's lasts like a couple of minutes and it's just cyclical. So this is again suggestive of abnormal increased intracranial pressure. Even though if it comes back to normal, this is not normal, needs to be treated on. And A wave, so sustained increased intracranial pressure for a period of like 10 minutes or so, it is definitely not normal and it's suggestive of very poor prognosis and highly increased intracranial pressure, and patient might be coning already. So some interesting waveforms which might be as limited. So the final MCQ for the first session, a patient with severe TBI develops fever to 39.5 degrees Celsius. Aggressive treatment of this fever is necessary because yeah, it's fairly straightforward, isn't it? I mean, other options are doesn't make much sense. So B is the answer. So this is a important management protocol for raised ICP. So it's a tiered approach. And this I've taken from the CIBIC guidelines, Seattle International Severe Traumatic Brain Injury Consensus, which is the recent one, and it clearly lays out the tiered approach. The tier 0 is basically the housekeeping measures, maintaining your heavy breathing circulation, head up, avoiding neck pressures, neck compressions, and maintaining a normal temperature, avoiding hypothermia. So that's what it says in the guidelines, not to aim for hypothermia, just maintain normothermia, avoid fevers more than 38, and like pain relief, sedation, seizure management, avoiding hyponatremia in tier 0. Tier 1 is our interventions, maintaining a low normal CO2 levels, using your hyperosmolar therapy, extraventricular drainage, or surgical decompressive craniotomy. Tier 2 comes the desperate measures like hyperventilation, paralysis, like heavily sedating the patient. And tier 3, nothing has worked, so you go for your last option, thiopentone coma or moderate hypothermia, which really helps decreasing the ICP when no other measures are working. So we basically upgrade from one tier to tier if the ICP is refractory. So that's the end of first session. What's time? Now it's 12:34. Why don't we have a short break? I will continue with the next session on burns and obstetric hemorrhage. So if we come back in 5 minutes, have a break, we will start with the next session. Unless you have any questions, we can discuss now or at the end of the next session. Then start with the next session on burns and obstetric emergencies. If everyone is back, give me a thumbs up or put a message if you're there. Okay. Give another minute before starting. Dr. Declan, which country you are practicing in?
I'm practicing from South Africa.
Oh, great. So
And I
second-
wanted to say
Yeah.
thank you so much for availing yourself on a weekend on a Sunday morning. We really appreciate your efforts.
I wanted to thank you guys as well. It's I don't know, in India, like it's a India-Pakistan match today, so on a Sunday, on a with a match, so everyone has sacrificed that time. So,
Very wow. Thank you so much.
so I think we should start. Let's not waste time. So I hope this is useful for you all. Okay. Cool. So patient is a 28-year-old burn victim with 40% total body surface area burns, 36 hours post-injury. Urine output has been steadily decreasing over the past 4 hours and is now less than 0.3 mils per kilo. He's on a mechanical ventilator with a PEEP of 10 and his abdomen is distended and tense. What is the most likely cause of this oliguria? ATN, myoglobinuria, inadequate fluid resuscitation, abdominal compartment syndrome, cardiogenic shock, or sepsis. Don't know if everyone has come back, but I think for short of time we will keep going. What do you think is the right answer? Great. Got some response. That is correct. Abdominal compartment syndrome. And why do you think the patient has gone into abdominal compartment syndrome?
Probably has received a lot of fluid with a fluid overload syndrome.
Yeah, it happens all the time with burns patients, isn't it? We give a lot of fluid if we just stick to like Parkland formula strictly. We load them with fluids and fluid trips develops abdominal compartment syndrome. And yeah, you're correct. That's the answer. Patient with large full thickness burns is undergoing escherotomy on the right forearm for clinical signs of compartment syndrome. The incision should extend along the volar surface only, dorsal surface only, medial and lateral aspects of the forearm, volar and dorsal surface along the lines of radial artery. Yeah, yeah, you are correct. Medial and lateral aspects. And there are like specific incision lines for each part of the body. I'm not sure of all the things, but we the aim is to avoid vessels and so wherever we know the vessel vascular anatomy and the neuroanatomy, so we can try and avoid those lines. Great. So which of the following is the least appropriate fluid for the initial resuscitation for burns? Ringer lactate, 5% albumin, normal saline, plasmolite, or FFP. Yes. So it's obviously FFP. And what do you think of the 5% albumin as a resuscitation fluid in burns? Bang on after 24 hours only. Yeah, so that's correct. We don't want to pay on the patient to be in the capillary leak phase. So when the patient is in active capillary leak phase, even the 5% albumin can leak out of, yeah, through the leaky capillaries. Exactly. That's why we try and avoid. And there is some evidence of harm with 5% albumin in some like subsets of patients. So that's why we should be skeptical about using 5% albumin in the initial phase, but can be used if required after the initial 24 hours phase. patient with severe smoke inhalation injury is most at risk for developing which of the following complication in the first 24 hours? Yeah, I understand why you are going for ARDS. That's what my initial thoughts were as well. But the key here is the timing, I think. Uh, so they mentioned like ARDS usually takes few hours to develop, usually peaks in like day 2 or day 3. And the immediate airway risk is at the risk of upper airway obstruction. So that's why Shrikant is correct. Upper airway obstruction is the right answer in the initial few hours after the severe smoke injury, especially with the inhalation injury. Upper airway obstruction is the most important concern, and protecting the airway is the high priority. ARDS does develop in few hours, but usually presents in day 2 or day 3. Burn patient is receiving high dose ibuprofen infusion for pain. So the best monitoring parameter to detect early respiratory depression is respiratory rate, end-tidal CO2, also oximetry, ABG, level of sedation assessment. Anyone else? What do you think? Dr. Shrikant says B. Do you all agree with that? Still deciding between B and D. D. Yeah. It is a bit difficult, isn't it? ABG is more accurate, but giving the most sensitive one, I think we are looking for the most sensitive one, right? Just looking at the trend of ETCO2, end-tidal CO2 may give you most, like maybe the first sign of respiratory depression. So I tend to go with B. ABG is more accurate, but we cannot keep doing continuous ABGs. We do it in like 2 hourly or 4 hourly or something. But end tidal, we have a continuous waveform, so that will be the first thing to not mentioned if intubated or not. But if we are monitoring end tidal CO2, I think patient is already intubated. I should have made it more clear, but thanks for pointing that out. Often the questions are like this, like sometimes we do get like incomplete questions, but we have to go with our clinical, yeah, we have to go with our, what the examiner is trying to ask. Yeah. So Brooks formula for Burns resuscitation calculates the total fluid requirement for the first 24 hours as so we all know Parkland formula. What is Brooks formula? So here you can apply the technique even if you don't know the answer for Brooks formula. You can try and rule out the other option and narrow it down to like 1 or 2 choices. Sometimes it just gives you the answer. So let me help you. Like, yeah, right, it says B. So B is the Parkland formula. So that's definitely not the answer. Let's look at C. 100 mils at a constant rate over 24 hours. We never do that. That's not the option. 4 mls with off given in the first 24 hours. That's too less thing. So that's not the answer. E could be the answer or A could be the answer. But the correct answer is A. So this is basically a modified Portland where we are trying to avoid fluid creep and abdominal complications like abdominal compartment syndrome. So we go for a more conservative approach to like 2 mils. And there is another formula like rule of 10, basically start at like 10 times the body surface area per animal per hour. So that will give us a rough idea of how much you need. So this is explained nicely in the Burns chapter of ESICM. So just go through that when you have time. These are like three different ways we try and do the fluid management. But all these are like just guidelines, but you need to assess individually each patient, whether the patient requiring more fluid or less fluid, and aim for a urine output of at least more than 0.5 mils per kilo per hour. So you know the formula, you just need to calculate it and come up with the answer for this. 42-year-old with 50% burns, 80 kilos, and what's the weight, what's the initial fluid requirement for the first 24 hours? Just a mathematical question. C is the correct answer. I'm not going to discuss anything about that. 40-year-old man with rescued from a firehouse, house fire, sorry, is confused and agitated. Pulse oximeter shows a SATs of 99. Carboxyhemoglobin level is 28%. So what is the most appropriate immediate management? Continue monitoring on room air, give high flow oxygen by a non-rebreather mask, give hydroxycobalamin 5 grams, start hyperbaric oxygen therapy immediately on site. Yes. So what do we think is the diagnosis? Your answer is correct. It is B. Just asking, yeah, what are we treating? Yes, correct. Carbon monoxide poisoning. Yeah, hyperbaric oxygen therapy is often not available at multiple sites, and it can be given if it's like carboxyhemoglobin level is very high and it's not responding to just oxygen. So we are just giving oxygen to reduce the half-life of carboxyhemoglobin level, basically, right? So yeah. 30-year-old male suffered electrical burns injury after low voltage shock. He became oliguric with worsening kidney function. What's the likely cause? Hypothermia, myoglobinuria, sepsis, hypocalcemia. Yes, you are all correct. Myoglobinuria and rhabdomyolysis. EDIC exam is often simple like this, more of clinical based questions. So I really enjoyed the exam. I didn't have to prepare too much. I just went with a broad mind, and it was fairly easy exam if you have read, like we have been reading these topics for years and years now, so it shouldn't be that difficult for to clear EDIC part 1. Right. 35-year-old woman is rescued from an industrial fire in a closed space. She is comatose, hypotensive, and has lactic acidosis, very high lactic. Carboxy hemoglobin level is 5. What is the most appropriate antidote? Sodium thiosulfate, hydroxycobalamin, methylene blue, N-acetylcysteine. So I agree with your answer of hydroxycobalamin. Can you explain what are we treating? Yes, cyanide, and why not sodium thiosulfate? It can be used for cyanide toxicity as well. So how do you select in between sodium thiosulfate and hydroxycobalamin? Basically, both can be used for cyanide toxicity, but the onset of action is a bit faster for hydroxycobalamin compared to sodium thiosulfate, and is often preferred over sodium thiosulfate. But both of them can be used. So I would go with hydroxycobalamin, like you said. Right. 32-week pregnant patient is admitted with acute severe hypertension and a headache. Magnesium sulfate is commenced for seizure prophylaxis. What is the first sign of magnesium toxicity? Reduced deep tendon reflex, respiratory arrest, cardiac arrest, feeling of warmth and flushing, prolonged QT interval. Yeah, it's just from the other options, we can just say it's A is the answer, right? If they have given, instead of prolonged QT interval, prolonged PR interval, that might have really confused me, because that will be the first sign of high magnesium levels. And feeling of warmth and flushing is a normal sign, even if we give magnesium to anyone, that would be there. So I don't think it's just that will be the option. And B and C obviously are the late signs of magnesium toxicity. And this is a nice table which shows the level millimoles per liter. Be careful with that. Sometimes it can be milligrams per deciliter. So here we have millimoles per liter. And therapeutic range, we target up to like 1.7 to 3.5. And if you look like here, if it's 2.5 to 5, you start to get increased PR interval and widened QRS, which is above the therapeutic range. So I did, like, this should be the first sign of magnesium toxicity, right? But we don't do that, pick that quickly. And if it's slightly raised, reduced deep tendon reflexes, then you get some neurological symptoms, drowsiness, sedation, slurred speech, double vision. Goes beyond 5, that's when it becomes really toxic with loss of deep tendon reflexes. So CNS first, then respiratory, then your heart. More like local anesthetic toxicity, to be honest. Yeah. Patient has a postpartum hemorrhage due to uterine atony that is unresponsive to first-line uterotonics and bimanual compression. The next step in management before considering surgery is they can't say C. Anyone else have any other ideas? Says A. So the correct answer is A. So if we go from the bottom, so the last option is hysterectomy, and just before that, you try train artery embolization, and before that, you try tamponade with Buckley balloon. And I tried to get a flow chart. I didn't get a proper one, but that's the way. So first line Utritonics, then you do bimanual compression, you try B-Lynch, you try tamponade with Buckley, then uterine embolization, then hysterectomy. So that's the progression step for like surgical intervention. Patient with type 1 diabetes mellitus is in active labor at 38 weeks. The primary goal for intrapartum glycemic control is to prevent maternal DKA, neonatal hypoglycemia, shoulder dystocia, and PPH. So correct option is neonatal hypoglycemia. So after delivery, so the baby's insulin level is going to be high if the mom's hypoglycemia is not corrected. So that's the reason neonates will go into hypoglycemia after birth, heart risk. That's why we should aim for a normal glucose levels in intrapartum. During a C-section for fetal distress, patient develops acute shortness of breath, hypotension, and cyanosis. Shortly after, she has seizures and develops bleeding, profuse coagulopathy. So the most likely diagnosis is so clinically it fits the picture of amniotic fluid embolism. So PG, you are correct. And other options are not really. Eclampsia should be considered, yeah. But with coagulopathy, it shifts more in favor of amniotic fluid embolism, especially with the picture of like during a C-section, it happens. So high risk of amniotic fluid embolism. And the management is generally supportive. There is no specific management. Yeah. Cool. Patient who is 12 hours postpartum complains of difficulty breathing, coughs up pink frothy sputum. She is tachycardic, hypoxic, and has bilateral crackles on auscultation. Most likely diagnosis is pulmonary embolism, amniotic fluid embolism, peripartum cardiomyopathy, aspiration pneumonitis, tocolytic induced pulmonary edema. Yes. Interesting. So Wright thinks tocolytic induced pulmonary edema. So how do you differentiate it from peripartum cardiomyopathy? TTE, yes, absolutely. We need to do it to rule out tocolysis induced pulmonary edema to be honest. But we will be getting a TTE anyway. And the clinical picture is fitting more. There is no clear history of giving tocolysis here. So that's one point against tocolytic induced pulmonary edema. And otherwise, it can present in a similar way. So TTE, I agree, and history is not really suggestive of usage of tocolysis. So that's why I'm more in favor. And it's more common as well, peripartum cardiomyopathy. And it can present up to 6 weeks postpartum. Yeah. So more in favor of peripartum cardiomyopathy. Yeah. Patient with severe preeclampsia, being monitored, develops right upper quadrant pain, platelet count is bit low, AST, LT elevated, LDH is elevated, most likely diagnosis. Right? Yes, it is ELP syndrome. So how do you differentiate it from acute fatty liver of pregnancy? What extra point in the history will suggest towards AFLP rather than ELP syndrome? Hemolysis, LDH. Again, AFLP presents with a coagulopathic picture, bleeding tendency, which is very difficult to control. So that will tilt the favor towards AFLP rather than HELP syndrome. Patient has PPH, estimated blood loss of 1,500 mils. He is tachycardic but normotensive. So uterus is boggy despite fundal massage. The next most appropriate step is we already discussed yeah. Okay. I think I didn't make it clear. The use of uterotonics because the option B is a bit confusing. But yeah, I should have framed the question a bit better. It is a bit confusing. Maybe I should have removed the B option. But more appropriate option even here is like you do both bimanual compression and administer uterotonics. Apologies for the IV oxytocin question. Option it confuses. 18. 26-year-old at 34 weeks of gestation presents with blood pressure of 170 over 110, headache, visual changes, brisk reflexes. Which drug should be administered to prevent seizures? Yes, straightforward. And we have strong evidence base to suggest like magnesium should be the prophylactic and treatment of choice for seizures in pregnancy and should be the first line of therapy. And here the patient is definitely in severe preeclampsia. So yeah, ignition stands. 34-year-old at 30 weeks with preeclampsia, which is the finding is the strongest indication for immediate delivery. Another straightforward. So that's the only severe feature here, right? B is the only severe feature which is suggestive of like immediate C-section. So that is the answer. So yeah, we discussed this question already, but there we go. Patient treated with terbutaline and steroids with antepartum hemorrhage becomes progressively tachypnic, most likely cause peripartum cardiomyopathy, localizes induced pulmonary edema, amniotic fluid embolism, acute MI. So here in the history, there is clear use of tocolysis. So obviously, that is more in favor, and it's well antepartum, like 29 weeks. So they're trying to push you more towards tocolysis induced pulmonary edema rather than the other things. Yeah. I think this will be the final one for this session. Woman develops tonic-clonic seizures due to eclampsia. She receives magnesium sulfate 4 grams. 30 minutes later, develops respiratory depression and absent reflexes. Best next step? You're absolutely correct. It is B. And what are the other treatment options? For magnesium toxicity, what are the other even supportive measures? Other measures will be to support the airway and ventilation if required, and go for like diuresis, like how you treat a calcium toxicity as well, and stop the magnesium. That's the first thing to do as well. Yeah, the intubation and ventilation immediately. It's not frankly mentioned like a patient is apneic or like desaturating, so that wouldn't be the first choice. Maybe giving oxygen might be the best option to start with, then give calcium. So out of these options, I would say just calcium gluconate. That's it with today's session. I think we have finished a bit early, so I'm happy to answer any questions in general or with related to the topics we discussed today.
Hi, good afternoon.
Yeah.
I just wanted to let my colleagues know that you don't need to be intubated to monitor the end tidal CO2. There's actually modalities where you can do it even if you are non-intubated. Some of them must actually have the pot to do it.
Yeah, that's correct. Yeah, I agree with you. Yeah. Thanks for being a sport, everyone, and answering all the questions. There. All the best for your exams. It's happening in 2 weeks, right? 2 weeks' time.
Yes, it is 23rd, yes.
Yeah, all the best for your exams.
Thank
Uh,
you.
yeah, if you have any burning questions to ask or anything regarding the exam, I'm happy to answer. Or you can always send the message to Fatma, and she can forward it to me if you have anything, any questions coming up later.
Thank you, sir. It was actually a very nice session for the students also, because the exam is like very near to them. And
Yeah.
aspirants, we have the next session on 8 o'clock, at 8 o'clock today. 8 o'clock.
Hello.
Okay, and there we'll be covering two domains, and next will be continued tomorrow onwards. Thank you, everyone.
Thank you.